Dr. Lucy Connell. She's from South Africa, and she's the program lead at Right to Care organization. She supports the prevention, care, and treatment services for HIV and associated diseases, working with governments and communities to find pioneering solutions to build and strengthen public health care. And Dr. Connell is also one of she was the chair of the TB Special Interest Group in South Africa that Hala presented in the previous session. Lucy, the floor is yours. Thank you.
Good afternoon, everybody, and thank you for this opportunity to share some insights that we have gained through many years of being funded by PEPFAR to work with and support our National Ministry of Health to strengthen HIV and TB services. And also, thank you for the lovely welcome to this very warm and friendly city. It feels very African, so I'm very at home here. And I just want to warn you, if I see anyone sleeping, I'm going to be obliged to sing, and you don't want that to happen. Right. I was asked to talk about maximizing engagement in care and adherence to TB preventive therapy. And this is actually not going to be just from the perspective of someone who needs to take RPT. I've decided to look at it, the interplay between the health system or the administration of the health system, the health worker, and the person with HIV who needs RPT. So I'm going to just take you through the timeline of the important milestones in RPT history in South Africa. And it's actually a very interesting story, and I'm telling it so that you understand as I go on how the policy environment interplays with health information systems and other things happening, for example, what's happening in the HIV space to produce the challenges or the facilitating factors that we've seen throughout our history. So if you look at that slide, you will see the red line is the number of people that were placed on RPT year on year, and these are from successive TB global reports. And similarly, the green line shows at the same time what was happening at a global level. And you can see that not much was happening in South Africa between 2009 and 2010, and then something really took off. And in the 2006 report, we got very nice congratulations saying South Africa contributes 59% of all people on RPT worldwide. So what happened then? Our RPT program really started in 2005. RPT recommendations were included in our first set of national antiretroviral treatment guidelines, and TST was needed to determine eligibility and duration of RPT at that stage. And needless to say, you can see there that uptake was extremely poor, largely because of the barrier of TST. We know the shortage of PPD is a massive issue, but not only that. In our country, the technical confidence and knowledge of how to raise a nice, tight little apical bleb is something strictly reserved for nurses who deal with trying to diagnose TB in very young children. It's something that other people don't know how to do. So it was a technical barrier as well as a supply barrier. Then what happened in 2010 in response to new WHO guidelines, our country produced updated guidelines, and this time dedicated, standalone, detailed guidelines. And it was accompanied by a huge effort on the part of our department to roll them out across the country with a fair amount of support. And why the numbers jumped up at that time is also because there was a massive national HIV testing campaign, which our former president, besides everything else we like to blame him for, supported magnificently and was a beautiful example of how political will can support public health. So the numbers ramped up there. The next important milestone, okay, I haven't been showing you the milestones. There are our dedicated RPT guidelines that led to that ramp up. And then it sort of plateaued after a while, and new IPT guidelines came in, and this time TST was back in. And not only was TST in with all the problems around TST, but the guidelines were very complex. If the person was on ART, there was a different approach to if they weren't. Depending on whether the TST was positive, negative, or not done at all, there were different approaches. So it was very confusing for health workers, that level of complexity. And so actually you can see following about 2014, the program suffered again. Then in 2015, new recommendations came in, this time once again as part of national ART guidelines. And now it's stipulated, what do you do when TST is unavailable? And that was a great simplification. So if TST was unavailable, which was most of the time, you had 6 months if you hadn't started ART yet, and 12 months if you had started ART. Much simpler message, okay? At the same time, however, something else happened. There was a hiatus in the recording, actually, not the reporting, of RPT amongst clinicians. And that was because health workers had a massive administrative burden. There were many paper registers that were as long as this that they had to fill in. And they decided, let's rationalize the registers, rationalize what indicators we want to collect to the most important ones. And the RPT register was a very big casualty in that process. But what else was a casualty? If you don't measure something and you don't have to write it down, in the health worker's eyes, it's not important. And RPT lost importance, and the whole drive to put people on RPT lost traction. Then something happened that made life a little simpler. UTT started, so universal testing and treating. And why that made it simpler was now the days when you had someone who wasn't on ART for perhaps years were gone. There were very few of those people, and now everyone could have ART as soon as they were diagnosed, and so everyone could have 12 months of RPT. So as a public health message, it became a lot simpler. And then you can see our government is responsive. How many times have they updated guidelines? We are very lucky in that sense. Then there was a circular put out by the National Department of Health that said, okay, we reiterate that you don't have to do a TST. That mustn't be a barrier to providing RPT, right? It's not necessary. And furthermore, we want you to start RPT on the day you initiate ART. It's safe, you're not going to kill the patient, and you're not going to have a problem or a big headache with teasing out side effects, because side effects are minimal. And as you will see, that has, I think that's been one of the key things that has allowed our initiation rate to scale up. Although you saw from Halle's presentation, it is still far below where we need to be. But that has really simplified things further. And what isn't on this timeline is that our government is about to release even further updated guidelines. That will just make things a whole lot more clearer and more simpler once again. Okay, so this slide tells you that in the one district in particular, we are performing very badly with regard to completing RPT. So you can see that there are blue columns and red columns. The blue columns were our RPT statistics before we did a huge file audit exercise, and the red columns are what happened once we had audited close on 4,500 files. So these patients are the patients who would have started RPT between October and March 2018. And what you can see there is that after audit, suddenly the number of people who started TIA fell. We lost 600 people. It actually made our performance look better, but for a wrong reason. And what we found was that this is where stationary and where you expect people to record is so important. The stationary doesn't lend itself to recording. So first of all, there was a mismatch at this time between the national guidelines and the clinical stationary where nurses and doctors used to write. So for example, at that stage, the national guidelines said, okay, you need to put people on RPT for 12 months when they're stable. And there was no definition of what stable meant. So it was up to the local areas to decide, was it 2 weeks, was it 1 month, was it 6 months? And when there was lack of leadership from the district teams, then of course it was up to the individual clinician to decide. Secondly, that necessitated that you didn't actually write in the correct space on the stationery when you initiated a patient, but you waited until they were stable, which led you to another piece of stationery that didn't actually allow you enough space to write what you're doing. So in other words, the stationery did not match what the guidelines required. So nurses would write any old information in that spot. And what the data captures were picking up were other funny things like appointments for pickups of drugs, etc., etc. So our TB Prev went up, but largely because 600 people didn't complete. You can see that suddenly, from 6,000 people having no outcomes, only 1,000 didn't have outcomes, but the rate of people completing did not rise at the same way, and that's largely because of the last columns on the right. You can see that many people interrupted, okay? They didn't complete a 12-month course. So we wanted to understand why didn't they complete a 12-month course. All those thousands of audits didn't tell us why, because the clinicians did not write why. They were not repeating the scripts. So recently, we did a further 100 audits, asking the auditors to look anywhere in the file from the front cover to the back for any hint of a reason why that person did not have a repeat script for RPT. And we thought maybe the nurse might have written stock out in the progress notes. They might have written somewhere obscure that the patient refused INH. So that's what we were looking for. Those were only people who interrupted but who didn't have a good reason for interrupting, like having died or having been lost to follow-up, transferred out during the time that they should have completed RPT. So we found that there was no evidence for 99 of those 104 patients. In only 2 cases could you find evidence that the nurse had noted a stockout. One time the nurse noted a hypersensitivity reaction, and in 2 other cases didn't fit either of those. So, similarly in another district, I'm just included this for you to understand that guidelines play a very important role. Our RPT completion rate is much better in that district, and probably the main reason is that that province believes you should only give RPT for 6 months, and as a colleague mentioned, a shorter regimen has less opportunities for you to drop out and for problems to happen. So there are interprovincial differences. As you can see, there have been many guideline changes with poor penetration to clinic level as to what exactly those are. There's been a mismatch between what the national guidelines are asking you to do and the clinical stationery providing clear prompts for you to record that. Our national indicator data set only measures who is eligible for RPT and how many people were started on RPT. It doesn't measure who completed. So you can see immediately, USAID wants us to measure who completed, and that is actually what you want. That's the endpoint you want to measure. But our national indicator set doesn't go there, and consequently, it has not designed the stationery to elicit completion information, and that's why we're seeing a lot of these problems. There is still very poor integration of HIV and TB services in the consulting room and also within our health information systems, although that's changing with the integration of TB and HIV into a single electronic monitoring system. And of course, there have been clinic level shortages, which are more a supply chain issue than an absolute national dearth of INH. We wanted to understand why are there so many blank script lines, because that is the single biggest reason why people don't complete. So recently we've conducted a series of focus groups followed by a very relaxed teaching session and planning on how to mitigate the problems that the nurses share. And this was done in a very appreciative paradigm, recognizing the fact that nobody wakes up and says, oh my God, I'm going to not give RPT in 10 people today, but rather trying to understand their issues, their opinions, what issues would make them remember to do these things better. So very hopefully they are all absolutely convinced in about the efficacy of INH in preventing TB. Concerns about side effects persist and resistance. There's this boogeyman of monotherapy. And because of HIV, monotherapy is like this bad thing. And so it's transferred into the realm of TB prevention, the fear of monotherapy. It can't be good in any form. And then we picked up generally quite a poor knowledge of RPT guidelines beyond who should get it. So someone mentioned contraindications being important. Have I got time still? 1 minute. Oh, my word. Okay. Yeah. So understanding of who should get it, but less understanding of who shouldn't. What should we do if someone interrupts it for 1 month, 2 months, 3 months? All those sorts of issues. Very poor understanding of also the science behind RPT, which is why there is a fear of resistance in those issues. And then also, they don't document the RPT stop date and outcome because there's no field or prompt. Okay, it made it a lot easier that we now initiate RPT and ART on the same day. Why? Because that's in harmony with the prompts on the clinical stationery. So now there's harmony with eligibility and start, but there's zero field or prompt for stop and outcome. People feel overwhelmed. There's a lot of missing files, disorganized stationery, and there was a lot of input on clinical level stockouts. So people said the fact that they know INH is not there means they won't prescribe it, but they never document that that is why they didn't prescribe it. And then, of course, that third quote there is not really a stockout. That's pure lack of planning and a bit of laziness. So we also went to some clinics that had 80 to 90% completion rates. They tended to be the smaller, more intimate clinics where there was time to interact with patients and you weren't overwhelmed by a huge queue that look at you with resentment every time you go to the loo. But what was key there was their engagement with their clients in explaining this is RPT, this is INH, you have to take it for 12 months, and explaining very well so that their clients themselves became advocates. You forgot to give me my RPT, I want my RPT. Numbering the script, saying this is dose 1, the next person writes this is dose 2 in red. Multidisciplinary teamwork, so involving the pharmacy assistant in clinics that we're lucky to have them. And also data clerks, so that each worker reminds the other one about what they did or didn't do. And then, of course, they did appreciate the PEPFAR partner support, and there was a lot of evidence in our audits of the clinics that were doing better, where they had been audited by the partner and a sticky note left in the file, please continue RPT for another 3 months. And a response on the behalf of the nurses. Okay, I'm going to jump past this. This is interviewing patients. So INH 300 milligrams in South Africa is a fluorescent yellow pill. It's big, it's noticeable. So we thought we would find out if there are patients that had taken INH that are not documented in the stationery, and if there are patients that are documented in the stationery but never took. Okay, so what happens is that, 2 seconds. No, okay, all righty, well you can read about it. But it's very recognizable and it correlates highly with the evidence in the file as to whether a patient took RPT or not. And practice is definitely improved, so we now have 3% of people who've never started RPT who should have, whereas the previous year it was 30%. And I just wanted to reiterate agency. Why are we now not giving patients their due? We don't talk to them anymore. A casualty of UTT was the 3 or 4 counseling sessions that previously used to cover RPT. Yeah. I think people will take their IPT if they are given the benefit of a couple of minutes explanation.